Hello, everyone. Welcome back to Karan Academy. I hope you're all doing super well. Today, we're going to be talking about cystic renal diseases. The four primary ones we'll be talking about would be, firstly, simple cysts, acquired cystic disease, and talking a bit about what that means. And then we have our two primary polycystic kidney diseases, our autosomal dominant and autosomal recessive. So starting off with simple cysts, they mean pretty much almost absolutely nothing in most cases. They are incidental, that happen with age, and most elderly patients who have an ultrasound for whatever reason will find a few cysts within them. The important thing to know is that most of these cysts are benign and they don't usually need treatment, and they're usually quite small, which are usually meaning less than 5 centimeters in their diameter, and mostly contain clear fluid. In some cases, and this is quite rare, you can have cysts associated with a carcinoma, particularly an RCC, obviously, and those cysts tend to be more complex cysts and tend to be hemorrhagic often. But that's not going to be a simple cyst. That would be a complex cyst. But a simple cyst is mostly benign, and please reassure your patients if you do see one. Now talking about acquired cystic kidney disease. Now, before we talk about this, just look at this picture. So you see tons of cysts, and if I were to look at this without knowing anything else, I would say this looks kind of like our polycystic kidney diseases, right? Because we have a bunch of cysts throughout the entire parenchyma, but it's not quite polycystic kidney disease. So how do the two differ? Because we have a whole bunch of cysts in both of them. Firstly, we see acquired cystic kidney disease almost exclusively in patients with renal failure. And this is not congenital, so there's no actual genetic mutation or link associated with them, unlike autosomal dominant or autosomal recessive polycystic kidney disease. Most of these patients, or 90% of these patients, would have been on dialysis for quite a long time. And therefore, this is kind of a common manifestation you see once your kidneys have already failed. It is linked to a 15 times increased risk of developing renal tumors. And this is because with that inflammation and that destructive process, you have a higher cell turnover. And as we know, that puts you at a higher risk of all types of cancers. Now moving on to our autosomal dominant polycystic kidney disease. This is by far the most common polycystic kidney disease you'll see in the community. It is also the most common inherited renal disorder and presents with bilateral polycystic kidney changes on both sides. It is quite commonly due to mutations in two particular genes that are worthwhile knowing for pathology. These are the PKD1 and the PKD2, found on chromosomes 16 and 4 respectively. Now with ADPKA, autosomal dominant polycystic kidney disease, you see a gross enlargement. So if you look at this, you kind of have these holes in them, but the kidney itself doesn't look grossly enlarged. In most cases, actually, the kidney with acquired cystic kidney disease would be quite atrophied and small because it's already failed. Versus with autosomal dominant polycystic kidney disease, you will see huge kidneys to the point where they often may be palpable, and they weigh about 1.5 to 2 kgs, and the normal weight of a kidney should be less than 200 grams. And you can see tons of these huge cysts, and that's another difference. The cysts with polycystic kidney disease are going to be much bigger than that of acquired. And mostly it would be containing a mixture of clear fluid, a bit of blood perhaps, and the prognosis isn't usually the best. It commonly causes renal failure. This happens about 48 to 60 years of age, and about 5 to 10% of these patients will be requiring, of 5 to 10% of all patients with autosomal dominant polycystic kidney disease will be requiring some form of renal replacement therapy. Now, the bad part about this is that it's typically asymptomatic until you present with renal failure. And then it presents with a triad, and it's usually a triad of hypertension, hematuria, and abdominal pain. Now, this triad doesn't always present. It actually only presents like that in about 15% of cases. But Again, important to know that you don't always have to have all three of them. If you suspect hypertension, you would order an ultrasound as part of your routine for if you suspect hypertension that doesn't respond to conventional therapy, as well as hematuria. In terms of extrarenal manifestations, the way I like to think about it is because this is a genetic condition that is causing cysts in the kidneys, you will have cyst-like things going on elsewhere in your body. The reason you get these cysts is because of issues with connective tissue, right? So either you're going to get cysts or you're going to have something to do with connective tissue. And the three important ones you need to know: A, you can have cysts in the liver, and that would just be called polycystic liver disease. You can have mitral valve prolapses, and that is to do with the connective tissue. Or you can have barrianeurysms, typically in the anterior communicating artery in the circle of Willis. And that's because of both of them. So an aneurysm is kind of a weakness in the wall that balloons out, right? So it's kind of like a vascular cyst, although I don't like using that term. It's a weakness in the actual wall because of connective tissue issues that presents with an aneurysm, and that puts patients with barrianeurysms at a significantly higher risk of developing a subarachnoid hemorrhage. In terms of how we treat autosomal dominant polycystic kidney disease, our mainstay of treatment would be supportive. So we would start them on an ACE inhibitor because we know that ACE inhibitors are renal protective, as well as they would help with BP control, which is a presentation of this disease. And also we have tolvaptan. I probably didn't pronounce it right, but what this new medication does, it basically slows down the formation of new cysts and is usually used in patients with autosomal dominant polycystic kidney disease who have gone on to develop chronic kidney disease. So worthwhile knowing, although I don't think it would be particularly high for assessments, that's a new medication. Now, on the flip side of that, we have autosomal recessive polycystic kidney disease. Now, how are the two different? A few key differences that are important to know. Firstly, that one was autosomal dominant, this is recessive. I think that's the main one that's obviously in the name too. Secondly, you have different genes being affected. So the genes affected here, went too far back, are PKD1 and PKD2. Here we have PKHD1 that's affected on different chromosomes. Those were 16 and 4. This is chromosome 6. Autosomal recessive polycystic kidney disease presents much earlier than the dominant type. This one presents almost at birth or in neonates and is a cause of early neonatal death, versus autosomal dominant, which presents mostly above the age of 30. So in their 30s or 40s is when most people would find out that they have autosomal dominant polycystic kidney disease. The next thing is that the size of the cysts is very different. As you can see here, you have these tiny cysts all the way through, but they're going to be much smaller than that of polycystic kidney disease, because as you can see here, these are huge size. These cysts are huge, right? And these are going to be very small. So it has a worse off prognosis than the dominant type as well, because as you can imagine, having this in a neonate is going to complicate things a bit more. And those who survive tend to have a lot of issues with their liver. As with the dominant type, you can have complications in the liver, and this happens here too, particularly cyst and fibrosis. And because this is going to present in neonates, it is going to also interfere with normal development of the liver as the kid grows on, versus the dominant subtype, which may have manifestations, but it's not going to affect the overall development of the liver. And that's all we had for cystic kidney diseases. I hope that all made sense. If you have any questions, please chuck me a message. And as always, please look after yourself and please look after your loved ones.